Hello everyone, my name is Jessica and today I will be presenting on my clinical case study. We will be following my patient LB. So to begin, I'd like to talk about the primary disease, which is diabetes mellitus. A lot of us has a lot of background of the pathology already, so I'd like to talk about some new information and about the prevalence of diabetes. So to begin, the National Institute of Diabetes, Digestive and Kidney Disease has shown that in the US, about 30 million or 9.4% of the population are diabetic. 7.2 million are undiagnosed cases, and 1.5 million new diagnoses of diabetes each year occur, which is a staggering amount if you think about it. For type 2 diabetes, it's most likely to increase with age. It has shown that 27% of the elderly in a community care home are diagnosed with diabetes. Often the symptoms are polydipsia, dysuria, retinopathy, neuropathy, foot ulcers, hypertension, gastroparesis, obesity, fatigue, weight loss, which reflects that in our patients they'll have frequent thirst, urination, hunger, but they'll still have weight loss. They'll have blurred vision, tingling in the hands and feet, and often foot ulcers will be slower healing, so that will be a concern as well. For gastroparesis, it just means with slower stomach motility and gastric emptying. They'll feel full, but still also have that weight loss as well, which could be a concern. Diagnosis is for diabetes mellitus to have a A1C test or the glycated hemoglobin test of greater than or equal to 6.5, a fasting glucose of less than 100 milligrams per deciliter, and an oral glucose tolerance test resulting in 144 to 199 milligrams per deciliter. In our second disease, I'd like to talk about chronic kidney disease. So basically, kidney failure can cause diabetic neuropathy, hypertension, lupus, nephrotic syndrome, vomiting, insomnia, urinary incontinence, UTI, edema, altered mental status. And often for chronic kidney disease, it can be diagnosed through blood or urine tests, kidney biopsies, CT scans. In our patient's case, this patient was in the final stage of chronic kidney disease or end-stage renal disease, where the kidney only operates about 10 to 15% of the normal function. So to our case, it was a 66-year-old Caucasian female with a social history of living at her home with her husband. She was married, and in the past, she did smoke about 2 packs a day for 50 years. She was admitted for altered mental status, tachycardia, hypotension, and sepsis. Her past medical history included a below-the-knee amputation on her left leg due to peripheral vascular disease, osteomyelitis, and a non-healing chronic ulceration on the left foot that happened earlier this year in August. Our patient had also multiple comorbidities, including hypertension, hypothyroidism, type 2 diabetes, chronic coronary artery disease, chronic heart failure, osteomyelitis, end-stage renal disease, and she was receiving hemodialysis on Monday, Wednesdays, and Friday. She also had a non-healing abdominal wound that was a result of a hernia repair 4 years ago. Our patient has a history of MRSA, bacteremia, C. diff infections, and in the past, along with her BKA, she also had a tubal ligation, a cholecystectomy, ventral hernial repair, creation of an arteriovenous fistula, left angioplasty, and a portacath. Currently, she had presented with the medical issues of sepsis. They had found a mitral valve vegetation, endocarditis, and bacteremia. Due to the altered mental status, it was a sign of metabolic encephalopathy. She needed a right leg amputation due to a great toe necrosis from a diabetic foot ulcer. And because of her end-stage renal disease, they found that her permacath was infected, which also furthered the problem of sepsis. She was a type 2 diabetic, and she also had hypothyroidism. For our nutrition care process, to begin with assessment, during the length of her stay, over 27 reported meals, she had an average PO intake of 4% over her whole length of stay, which is very grossly inadequate. For mealtime behavior, per the nursing notes, we had found that the patient was choosing to be NPO and non-compliant with PO intake. And because of the left below the knee amputation, metabolic encephalopathy, soft restraints, and altered mental status, she required assistance for her feeding, and at home as well. She needed assistance making the food and setting up. For the weights of her during her admission, it had shown that in the beginning of her admission, she was about 77.8 kilograms. And even though it did fluctuate throughout her length of stay, we did notice a decreasing trend overall, slowly, gradually going from 75, 68, 66, 63. We did take into the account of hemodialysis, but even still, within a span of 17 days, we had witnessed an 18% weight loss with a difference of 14.3 kilograms of body weight. Her medication prescription included a list of antibiotics, antihistamines, anticoagulants, her fast-acting insulin analog, a probiotic, hormones for her hypothyroidism, a couple of opioids for pain management, as well as a sodium chloride at 9% for 20 milliliters just to maintain fluid and electrolyte balance. For her anthropometric measurements, we found that she was 5'7", her weight was about 77.9 kilograms, or about 171 pounds, and her BMI was calculated to the right. She was at 26.9, and she was in the overweight category. We did have to adjust her weight for her left below the knee amputation and later her right above the knee amputation, and that was where we got the percentage. So her adjusted weight was 52.6 kilograms, or 115 pounds. For my nutrition-focused physical findings, because at times the patient was in and out of consciousness due to her altered mental status, she was also shouting, and she did seem to be confused during my multiple attempts in visits. For her extremities and muscle bone, I did find slight depressions on her temporalis and pectoralis muscles. I also did confirm that she had a left below the knee amputation. And during a visit later on, I did also confirm that it was a right above the knee amputation as well. For her head and eyes, there were dark circles, depressions, and loose skin. For calculating her estimated energy needs, we calculated one at the beginning of her admission and then later again on from her recalculated weight because of the weight loss. So we had calculated the MSJ, and we used an activity factor of 1.3 to 1.5 using the original admit weight of 77.8 kilograms. And on the 8th of November, we calculated again, except 1.3 and 1.6. We adjusted the activity weight factors a little bit higher to account for the healing process. For estimated protein needs, we did take into account of hemodialysis and the full thickness wound, as well as her leg amputations. We needed that caused her protein to be a bit higher. So again, it was about 1.3 to 1.5, and then afterwards we recalculated to 1.3 to 1.6. For her fluid estimation needs, we gave about 1 milliliter per kcal, so that rounded out to about 700 milliliters, but we also wanted to give nephrology ability to alter fluid needs if necessary. So for our first nutrition diagnosis, we found that there was inadequate oral intake related to altered mental status, decreased appetite, as evidenced by PO intake of less than 50%. Later on throughout the visits, the diagnosis changed where we had deemed that due to severe protein-calorie malnutrition in the context of acute and chronic illness related to poor appetite and cognition impairment, as evidenced by severe weight loss of 18% in 17 days, or poor PO intake of an average of 5% in 17 days. We did diagnose the patient as malnourished, but unfortunately the doctor did not agree with our findings. We believe that because of the acute context of her NPO status, that she was in fact malnourished, but the doctor did not sign off on that, unfortunately. So for the interventions, we wanted to her have a consistent carbohydrate diet to match her diabetic needs for diabetes. Mechanically altered, she was later put on a pureed diet, confirmed by the speech pathologist. We did have commercial beverages as oral nutrition supplements. We had her on a multivitamin, which was Nephrite for the renal disease patients. Because of the patient's need, we had the patient set up meals and positioning the patient for the nursing communications. And in the beginning, when she was first admitted, we had given her a diabetic diet education. From her first admission on October 22nd, she was NPO. Later, she had advanced to clear liquids, where we had supplemented the patient with Ensure Clear 3 times a day. But on the 26th, she was placed back on NPO for a TEE, where they found that she had mitral vegetation. On the 27th through the 29th, they had advanced her to clear liquids, and we again wanted to make sure that she had Ensure Clear, but we also put Juven on there for when her sepsis had subsided. On the 29th, we also had put tube-free recommendations because we had seen that due to poor PO intake, this was going to go down a bad route if she wasn't able to eat and she needed extensive surgery. So for the first tube feed recommendation, we had suggested Nepro with a goal rate of 45 milliliters per hour to provide about 1944 kcals, 80 grams of protein, 783 milliliters of water, and that would meet about 114% of her daily values. We had suggested to initiate at 20 milliliters, advancing 15 milliliters every 12 hours, should electrolytes remain stable to goal. The patient was at a risk for refeeding, so we had suggested to check phosphorus, potassium, magnesium levels for 3 days and to replete as needed. We left flushes and fluids per MD and nephrology. On the 29th through the October 5th, we had seen that her diet advanced to a consistent carbohydrate, 60 grams, and puree. Again, we had put in further tube feed recs as the same as before, and we also included TPN recommendations as well for 1750 kgals at a dosing weight of 77.8 kilograms with a goal of 110 amino acids. We used 1.4 kilograms for her 77.8 kilograms because of the full thickness abdomen wound and the great toe necrosis. 282 grams of dextrose with a GIR of 2.5, 35 grams of fat to meet 20% of the total kcal. Again, the patient was another risk for refeeding, as at this point she had been inadequate PO intake for 10 days. We also had thiamine, 100 milligrams daily until dextrose at goal with stable electrolytes, and we suggested to begin dextrose at 25%. Titrate as the blood glucose and electrolytes stable. We had caution for total volume during the refeeding period, and we left the total volume insulin requirements and electrolytes adjustments for nephrology, the MD, and pharmacist, and the patient would need a central line access. We left the Nepro for twice a day, and we had suggested an appetite stimulant on November 1st. On the 6th of November, the patient was NPO for her right above the knee amputation. On the 7th and 8th, she was back on the consistent carbohydrate puree diet. We had recalculated the tube feeds and TPNs below, and this time we had advanced the Nepro to 3 times a day, and we added a Nephrovite daily. For adjustments, we increased, we put the Nepro at 40 milliliters, provide 1728 kcals, 78 grams protein, 696 milliliters of water to meet 101% of the RDIs. We would initiate at 15 milliliters and advance 15 milliliters every 12 hours. Again, refeeding risk. For TPN, we had changed it to 1570 kcals at a dosing weight of 63.6 kilograms, 100 grams of amino acids, 256 grams of dextrose, and 30 grams of fat. She was refeeding risk of 17 days of poor PO intake. At this point, speaking with nurses and family, the patient was eating very minimally, as well as only taking few sips of 1 Nepro per day. For monitoring and evaluations, we wanted to reinitiate nutrition to meet at least 50% of our estimated needs through PO intake within the next 3 days. That was during the initial NPO diet order. We saw her again, and we wanted to initiate an alternative form of nutrition within the next 24 hours to prepare for surgery to meet at least 25 to 50% of our estimated needs for PO intake over the next 2 to 3 to consider an alternate source of nutrition should the patient fail to meet the above, and to meet 50% of estimated needs within the next 2 to 4 days within the confines of the disease state from PO intake and oral nutrition supplements. Unfortunately, during the whole length of stay while I was there, the patient was unable to meet any of these goals when I had visited her, and because of the patient's family's wishes, they had wanted her to continue PO intake and did not consider any aggressive form of nutrition treatment. So they did not consider the tube feeds or the TPN recommendations. While I was following this patient, the patient did get discharged to a long-term acute care hospital back in Georgia where her family was, and her diet had stayed at the consistent carbohydrate, 60 grams and puree, and we left the consistency per the speech pathologist. And the oral nutrition supplements, we had suggested Nepro 3 times a day because the patient was willing to drink the Nepro at least. The Neprovite daily, and to continue Juven 2 times a day for at least 30 days post-discharge to help with the wound healing process. In the future, it would probably be beneficial to start diabetic education early on as soon as the patient was diagnosed, and to introduce increased protein intake for wound healing and hemodialysis. And these are my references.